the next session, the session 7. The topic is basic anatomic training with prostate biomodels. I think this is really one of the interesting session, and we have valuable speakers from Hacettepe University. And I will co-chair with Professor Mehmet Gülüm from Hacettepe University this session. And we have a 10-minute delay. I request from all speakers to obey their time. And our first speaker is Professor Muzaffer Eroğlu from Hacettepe University. He is also one of the uro-oncologic surgeon, and he will talk on anatomic important landmarks related to open prostate surgery. Please.
Thank you very much. Good morning to everybody. Someone can... Aktarma. Ekran açık.
Işıkları bu kadar karartmayalım. Çünkü kayıt yapıyoruz. Bu sunuları web sitesinde yayınlayacağız.
Is that okay? Tamam. Biraz daha
Evet.
Good morning to everybody. Today I will talk about anatomic important landmarks related to open prostate surgery. Sorry, what I will do the slides. The human prostate, a walnut-sized organ at the base of the bladder. Even it is so small, it causes three major comorbidities. These are prostate cancer, BPH, benign prostate hyperplasia, and prostatitis. Although ovoid, the prostate has anterior, posterior, and lateral surfaces with a narrowed apex inferiorly and broad base superiorly that is contiguous with the base of the bladder. Oncologic efficacy is the primary goal of radical prostatectomy. Preserving potency and continence is also important. In order to preserve and recover postoperative potency and continence after radical prostatectomy, a detailed understanding of the pelvic anatomy is necessary to recognize the optimal nerve-sparing plane and minimize injury to the neurovascular bundles. The relations of prostate is important. Superiorly, it is contiguous with the bladder neck. Anteriorly, it is separated from pubic bone by a fat tissue. Posteriorly, it is separated from ampulla of the rectum by Dennetviller fascia. Inferiorly, it is rests on the urogenital diaphragm. Laterally, it is embarrassed by levator ani muscle. The prostate lobes are important for open surgery, especially in benign prostate hyperplasia. Lateral lobes are enlarged after 40 years. But sometimes not only lateral lobes, but also median lobe may be enlarged. Even some patients, only median lobe is enlarged, and patient may suffer from severe lower urinary tract symptoms because during urination, this median lobe acts as a urethral valve. This is the cystoscopic appearance of the prostate from inside. These are lateral lobes, this is verumontanum, and this is urethral crest. These are specimens from open simple prostatectomy. Here we see another enlarged middle lobe and lateral lobes, and this is from our operation which we done last week. Here middle lobe, here retropubic space, and this is bladder mucosa. What is digital rectal examination? It's a part of urologic examination. Digital rectal examination is important in urology. A doctor inserts a lubricated gloved finger into the rectum and feels the prostate posterior surface and try to make a guess about the prostate disease. Urologists can sometimes detect an enlarged prostate, lumps or nodules or prostate cancer or tenderness from prostatitis by doing digital rectal examination. Also, prostate has 4 zones. These zones are important. The green part is peripheral zone. This one is important for prostate cancer. 70% of the prostate cancer arise from this zone. Also, while we are doing rectal examination, we feel the surface of peripheral zone. The yellow one is the central zone. Transition zone. The BPH is rise from here. Even it is small in a young man, if BPH take place, sometimes it constitutes 90% of whole prostate. The pink region is central zone. It surrounds the ductus ejaculatorius. Ductus ejaculatorius brings semen from vesicula seminalis and testis to the urethra. The anterior fibromuscular stroma, normally there is not much glandular tissue, and it extends to external striatus sphincter. In this slide, we see that transitional zone surrounds the urethra. Central zone surrounds the ductus ejaculatorius. Prostate capsule. Although some authors believe that prostate has a real capsule, in reality it doesn't exist. Actually, the fibromuscular layers around the prostate glandular structure is called prostate capsule. It is false prostate capsule. Prostatic urethra, it's transversed by prostate. It extends from the bladder neck to urogenital diaphragm. As prostate, it is located between 2 sphincters, internal and external sphincters. Prostatic urethra consists of transitional cells similar to bladder epithelium. Also, there is verumontanum, urethral crest, and openings of ejaculatory ducts in prostatic urethra. What about the fascias? Pelvic fascia, the other name is endopelvic fascia, covers all organs in pelvis and pelvic muscles. If fascia covers the pelvic muscle, it's called pelvic parietal fascia. If it is covers the organs, it's called pelvic visceral fascia. But in front of the pelvic fascia, which covers the prostate, is also called periprostatic fascia. There are 3 fascias around the prostate. One of them is periprostatic fascia, is a part of endopelvic fascia. The other is prostatic fascia, it surrounds the whole prostate. And the third one is denovillar fascia. It is located posterior of the prostate and separates prostate from rectum. The nomenclature of the fascial structures around the prostate is not well standardized. The denovillar fascia separates dorsal the prostate from the rectum. This fascia adherent to prostate Also, this fascia covers the surface of the posterior surface of the seminal vesicle. Sorry. Pelvic fascia, parietal part of pelvic fascia, a strong membranous layer covering the levator ani muscle. Can you see it? Ani muscle, obturatorus internus, piriformis, and coccygeus muscle. And this fascia is continuity with the fascia transversalis inside the abdominal wall. Here we see them. Prostatic visceral fascia, the other name is periprostatic fascia, encapsulates the individual organs within the pelvis. Name it according to the organ it covers, such as vesical, rectal, or prostatic fascia. Also, it covers the pelvic nerves and vessels surrounding prostate, dense fascia. The prostatic fascia surrounds the prostate and anteriorly and laterally. Laterally, it fuses the endopelvic fascia. Posteriorly, it fuses the denonvillar fascia. Endopelvic fascia also surrounds the rectum, and it looks like a H letter. The neurovascular structures tend to be located posterolaterally, but may not always form a bundle. A significant proportion of fibers may lie away from the main nerve structures along the lateral posterior aspects of the prostate. It is widely admitted that the knowledge of the anatomy of the fascia surrounding prostate is necessary to perform a nerve-sparing radical prostatectomy. The planes are very important during performing a nerve-sparing radical prostatectomy. There are three planes: extrafascial, interfascial, and intrafascial. If we make a dissection extrafascial, here neurovascular bundle, we resected the neurovascular bundle with prostate. It means that we didn't preserve the neurovascular bundle, and if we do bilaterally, the patient may suffer from impotence or incontinence after operation. If we go between the periprostatic fascia and prostatic fascia, it is called interfascial plane. Then it means that we preserve the neurovascular bundle partly. If we do between the prostate capsule, not through capsule, and prostatic fascia, if we make a plane here, then it's called interfascia. Then it's called intrafascia, and it means that we preserve the neurovascular bundle completely, and the patient shouldn't be suffer from impotence or incontinence after operation. The denonvillar fascia is located posterior side of the prostate. It's also called rectoprostatic or rectovesical fascia. It is covered the entire posterior aspects of the prostate. It was composed of thin anterior layer covering the seminal vesicles. Also, this fascia protects rectum cancer and prostate cancer to invade each other. It's a barrier between the prostate and rectum. Also, the denonvillar fascia called the plane between the wind and water. This is white line. It is a border of pelvic visceral fascia and pelvic parietal fascia. If we make a dissection lateral side of this white line or arcus tendinous of pelvis, if we make a dissection lateral side, it means that we will not protect the neurovascular bundle. Here, pubis bone. This is a photo from robotic surgery. Here we see white line. Can you see mouse? No. Here, white line. This is a incision lateral side of the white line. This is puboprostatic ligaments, which the extension of the detrusor muscle and its continuity with the puboprostatic ligaments. It's covers the anterior side of the prostate. It's important during prostate surgery. We generally make a stitch here to prevent back bleeding, because we will cut the deep dorsal vein. That's why we will make 1 or 2 stitches here. That sort of is important. Here we see also that two options here, not here. This is here puboprostatic ligament. It goes to prostate. From prostate to pubic bone. Here we see the puboprostatic ligaments. They are extending from prostate to pubic bone. Actually, it is pubovesical ligaments, but prostate is enlarged, and that's why it looks like it goes from prostate to pubic bone. This is operation photo here, puboprostatic ligaments. This is a cadaver photo here, puboprostatic ligaments. This is also another cadaveric photo. These are puboprostatic ligaments. During the operation, we prefer to cut it before operation, because if we cut it, we will stitch a thinner dorsal venous complex. Also, pelvic plexus is important for prostate surgery, especially during nerve-sparing radical prostatectomy. The anatomical nervous system is directly responsible for penile erection. The inferior hypogastric plexus, the other name is pelvic plexus, is responsible for the mechanism of erection, ejaculation, and urinary incontinence. The pelvic plexus contains sympathetic and parasympathetic components. The sympathetic fibers rise from T11 to L2 ganglia, while the parasympathetic fibers originate from the ventral rami of sacral 3 and sacral 4 levels. The nerve is called nervus erygentus or cavernous nerve. Here we see the nervus erygentus. It comes from pelvic nerve. Pelvic nerve get fibers from T1, L2 levels and sacral levels. Radical prostatectomy is a main option for the treatment of localized prostate cancer. Impotence is a common side effect of this intervention and impact highly on the quality of the life of survivors. Nerve sparing surgery, unilateral or bilateral. If we do unilateral, generally patients preserve their potency. The aim of the sparing at preserving the neurovascular bundles localized close and laterally to prostate. The neurovascular bundle, it runs the groove between the prostate and rectum. It contains nerve fibers that come from pelvic plexus. Vascular veins comes from deep dorsal penile veins, and artery comes from interior vesical artery. The other photo, we see the neurovascular bundle, vein, artery, and nerves. Prostate and ureter, straight sphincter here, inferior side of the prostate. Dorsal venous complex also important during radical prostatectomy, because sometimes it's bleeding very much. Especially young specialists are afraid of bleeding. Normally it comes from deep dorsal penile veins, and it gives a small branch anterior side of the prostate, and it goes as a hypogastric vein. If we don't cut the prostatic ligaments, it's a bit difficult to control the dorsal vein complex. This is a cadaver slide. Also, we see smooth muscles, sphincters, and dorsal venous complex are as an empty hole because it's cadaver. Also, there are two sphincters about the prostate surgery. One of them is internal sphincter and the other is external straight sphincter. Internal sphincter is located at the bladder of the neck and it is innervated by splenic nerve and works involuntary. Straight urethral sphincter is located at urogenital diaphragm and it works controlled by pudendal nerve. As you see, prostate is located between these two sphincters. The green region is membranous urethra. It's surrounded by external straight sphincters. This is a schematic slide about sphincters. Also, verumontanum is important for prostate surgery. It is located in the prostatic urethra. There is a small hole at the tip of it. It is called utriculus prostaticus. Some of the students and residents think that semen comes from here, but this is a blind-ended portion. It's a remnant of Mullerian duct. Opening ductus ejaculatorius are here. This is a blind-ended. Sometimes it's bigger in ambiguous patients, but in a normal patient, it's not very big and important. Verumontanum makes a crossroad between the urinary and genital tracts. During endoscopic surgery, for example, transurethral resection, it acts as a landmark of straight sphincter and it is accepted lower limitation of the intervention. Vesicula seminalis are located superior and posterior to the prostate gland. This was deferentia, singular was deferens, bringing sperm from the testis to the seminal vesicle. The seminal vesicle contribute fluid semen during ejaculation. The journey of spermium from testis to the vesicula seminalis takes about 70 days. These are ampulla of the ductus deferens. And the ductus of vesicula seminalis is called ductus excretorius. Ampulla and ductus excretorius merge and form ductus ejaculatorius. We can see here, it's inside the prostate. Maybe here we can see. Ampulla of the ductus deferens, they are medial side of the vesicula seminalis, and ductus excretorius, and here is ductus ejaculatorius, ejaculatory duct. It goes to side of the verumontanum. This is another slide about it. Ductus excretorius, ductus ejaculatorius. The vascular supply of the prostate also important. Vascular injury, namely arterial insufficiency and veno-occlusive leakage, is becoming increasingly implicated as a cause of erectile dysfunction after radical prostatectomy. Most commonly, arterial supply of the prostate rises from the arteria vesicalis inferior. As it approaches the gland, the artery divides into two main branches. One of them is capsular artery. They give small branches to capsule. The other is urethral branch. It gives the blood to periurethral glands, transition zone, and bladder neck. This branch is responsible for the BPH enlargement. Thank you very much.
Thank you, Professor Eroğlu. Any question or comments on very popular topic of prostate? I would like to ask you one question, okay, because of we will perform tomorrow for students, especially for students, and also the residents. I think the appropriate digital rectal examination, and this is I would like to show, but only for show. Tomorrow you will fill it. This is the prostate model. You can do the digital rectal examination. One of the harvested by the diffusion prostate MRI is the real patient data. So can you give us a step-by-step digital rectal examination for tomorrow? Our students should follow.
Now,
No, yes, only
First of
very
all-
briefly.
first of all, you should say the patient, what will you do? Sometimes the residents or the others don't say, and patient can be angry with you, maybe fight with you. That's why you should say what will you do. And patient must be relaxed. In a room, he is bending forward, and you should wear a glove, and you should lubricate your index finger, and while you are starting, you should say it again. Now I am doing a rectal examination, and it shouldn't be very hard and shouldn't be very long, because some of the patients feel shy. That's why you will feel sometimes your finger can't reach the prostate because of the bigger gluteus maximus. That's why maybe you should say the patient tract your gluteus, or pull your gluteus, and should reach the end of the prostate. You should feel two tips and small hole between them, and if it is like a rubber, or it's like a stone, or not stone, wood, it's important. But even you shouldn't feel a prostate like wood, it doesn't mean that he doesn't have prostate cancer. But if you feel, maybe after prostate digital examination, you can never say that patient you have prostate cancer. Always you should do prostate biopsy.
Thank you. Second speaker is Dr. Ahmet Tuncay Turgut. I invite Dr. Ahmet Tuncay Turgut for his presentation.
Küçük bir uyarım olacak. Siyah BMW 06 VSL 21 aracın sahibinin anahtarına ihtiyacım var. Bilginiz olsun. Bu aracın yerini değiştirmesi gerekiyormuş.
Kime vereceğim?
Prostate imaging,
Injection.
ultrasound, MRI, physio and bio.
Siyah BMW. Bir şey diyeceksin şimdi ama yanımda mısın?
Efendim?
Duyuru yapmazdım. Çok teşekkür ederim. Hemen vereceğim. Buradayım zaten ben.
Good morning, ladies and gentlemen. First, I would like to thank Professor Huri and the organizing committee for their kind invitation. This is really a very nice meeting. So, I would like to talk about the imaging aspect of prostate. Today, I'm going to talk about the prostatic diseases, the role of imaging in the evaluation of prostatic diseases. Of course, this is a very wide topic, and it's very difficult to give a didactic speech in 20 minutes time. So I will focus on prostate cancer, the role of imaging in the assessment of prostate cancer. Imaging is used for the evaluation of prostate anatomy, as well as morphological and functional changes in the prostate in patients with prostate cancer. Of course, that would be nice if only this famous guy had only prostate cancer, but unfortunately, the disease is quite common. Here you see the estimates for 2017 according to American Cancer Society. Here you see that about 160,000 people are affected by prostate cancer, and almost 26,000 people were expected to die due to prostate cancer. The urologists usually have a wide spectrum of treatment options for prostate cancer. As you see, up to 50% of the treatment tools depend on surgery, but we also have other tools like focal therapy, active surveillance, and other modes of treatment. And the ratio of these treatments or the application of these treatments in different countries and different centers rely so much on the imaging tools. And we all know that the determination of the localization and the extent of the tumor, localization and extent, is very important because this enables the treatment of the disease at an early stage. An early stage means, as you know, a stage when it is curable and a stage that increases the survival rate. But unfortunately, we have some challenges with prostate cancer. These challenges start from detection and localization of the disease, and the other aspects or the other phases of the management also are quite challenging in prostate cancer. We have several diagnostic tools. The rectal physical examination, of course, is very important, but unfortunately the specificity and the sensitivity is not that high. And we know that some cultural factors sometimes may preclude the patients from having physical examination. PSA is quite good, but unfortunately there are some problems. Again, a significant percent of patients with abnormal PSA do not have prostate cancer, whereas some prostate cancers are accompanied by normal levels of PSA. And what about imaging? In imaging, we try to evaluate the body and the prostate as well in a three-dimensional model. So we always rely on a three-dimensional way of thinking. We use the coronal plane, sagittal plane, and the axial plane, as you know from anatomy. So almost all these imaging tools rely on this multiplanar evaluation of the prostate. And among these tools, transrectal ultrasound is the most commonly performed one. It's quite available, it's cheap, and it has some other advantages. And we also use MRI. So I'm going to talk about these main diagnostic imaging tools. We use a transrectal probe for the evaluation of the prostate. It has some tools that we call transducer on the probe. So these transducers enable us to evaluate the prostate in longitudinal plane and also in axial plane that we are going to see later. And we use a sweeping motion, as we see here. And with this sweeping motion, we scan the prostate in the axial planes, as you see here. So these planes change. According to our movement. We see some images that we obtain from this ultrasound evaluation, different images of prostate cancer. It may be in a nodular form, it may be in a diffuse form, or it may be combined. It may also be seen like a hypoechoic or black nodule in the inner gland. So it's possible to see prostate cancer in different appearances. However, conventional transsectal ultrasound, unfortunately, is not that satisfactory. It's not that accurate for the evaluation of prostate. But for evaluation of prostate, we use the schematic anatomy, as you see here. The inner gland of the prostate is wrapped by the peripheral zone that we see as black here. So this is our main area that we focus on during the evaluation of prostate cancer, as most of the cancers are located in peripheral zone. You see the motion of our hand and the probe. So we move downwards, we move upwards. So according to these movements, the plane that we scan in the prostate changes, and we also do this sweeping motion in the longitudinal plane as well. As I said, according to these movements, we scan the prostate at different levels, and we obtain the image at that level. As you see here, starting from the level of the seminal vesicles, we go down to the apex, and according to the place that we scan, we obtain different images of the prostate gland. We do the same thing in the longitudinal plane. We have ultrasound images starting from lateral aspect of the prostate, and we go towards the median, and again we have a different image of the prostate. This is the axial scanning. So you see the hyperpelagic inner gland and the peripheral zone. We do the same scanning in longitudinal plane. We start from the most lateral part of the prostate. We go towards the median lobe, very hyperpelagic median lobe. We also incorporate color Doppler ultrasound to the ultrasound examination. So you see a asymmetry here, an abnormal vascularization. So symmetry is very important. In imaging, we always evaluate the symmetry. So if we see any asymmetry in any imaging tool, this is suspicious for abnormality or pathological findings. As I said, ultrasound is not that accurate. A significant percent of patients with normal ultrasound may have prostate cancer, whereas those patients having positive findings on ultrasound may not have prostate cancer on the other hand. And unfortunately, again, color Doppler ultrasound does not preclude the need for doing prostate biopsy in patients. So, on the other hand, prostate cancer is quite successfully diagnosed by MRI. It's a much better diagnostic tool for the evaluation of prostatic tumors, for the detection and localization especially. And it provides, as I said at the beginning, anatomical and functional information which corresponds to tumor biology and aggressiveness. It can also be used for targeting prostatic tumors, as that we will see some examples later on. So we use sequences during prostate MRI examination, and for each sequence we obtain a different information for the prostate. For example, with the conventional MRI, with the T1 and T2 sequences that we use, I will not go into technical details, we derive some information about the anatomy, whereas diffusion-weighted MRI, dynamic contrast enhanced MRI, and the magnetic resonance spectroscopy, which we do not use nowadays for the evaluation of prostate, we obtain some data about the function of the cancer. So you see a wide spectrum of indications for prostate cancer. It can be used for staging, for detection, for localization, for assessment of the tumor aggressiveness, and so on. And when we see a pathological finding or an abnormality on MRI, we assign a score to this abnormality. This is called PIRAS scoring. And this scoring corresponds to the probability of cancer for these tumors. Starting from PIRAS 1, we go up to PIRAS 5. And this corresponds to an increase in the probability of prostate cancer. And we almost always recommend tissue sampling, I mean biopsy, for PIRAS 4 and 5 lesions, whereas PIRAS 3 is a little bit in debate in regard to the recommendation for biopsy. So here we see the anatomy on MRI. We see the peripheral zone, this times white, as you see here, and the inner gland, composed of this transitional zone, central zone, and so on. This is heterogeneous usually. We also see seminal vesicles, and we do the scanning again in multiplanar evaluation. Here you see we do the scanning starting from the upper third of the prostate. We go down to the lower third of the prostate, and according to the plane that we scan, the appearance changes. For example, in the lower third, we usually have a peripheral zone image, as we will see, whereas in the uppermost third, we have an appearance composed mostly of transition zone. Now we go downwards, starting from the apex, seminal vesicles. Here we see the seminal vesicles. So we have the appearance of the inner gland and the peripheral zone from this stage on. Here you see the peripheral zone in the inner gland. We go downwards. It's mostly homogeneous, the peripheral zone. We go downwards, we go down to the apex. And this is the scanning in coronal plane. We start from the most anterior part, we go towards the posterior part, as we will see here. We see the inner gland, the transition zone. We see some cystic structures here. We go, as you see, peripheral zone in the coronal plane. So we always try to think about in a three-dimensional models. When we see a lesion in one plane of scanning, we should try to assess where it can be located in the sagittal plane, for example. So what we do after detecting these lesions? Of course, the gold standard for the diagnosis of prostate cancer is prostate biopsy. This is the conventional mode of, or conventional schematic drawing for prostate biopsy. We do the sampling, as you see in the coronal image, the lateral and the paramedian aspect of the prostate gland. We do mostly, the urologists do mostly 12-core scanning. Unfortunately, it did not work. This was a conventional biopsy video. So when we see a lesion, we try to sample this lesion in ultrasound, but unfortunately, the lesions that can be detected on MRI are usually not detectable in ultrasound. So we do a blind sampling in the peripheral zone. We try to assess where the lesion that we detect on MRI can be located on ultrasound. Of course, this decreases the accuracy of the sampling. We do as I said, blind sampling. We cannot call it targeted with conventional biopsy. In this way, the important cancers can be missed. For example, it's not possible to see this significant portion or the lesion in general on ultrasound. So these cancers can be missed. And also it's possible to see an overdiagnosis of insignificant cancers like here. And because of this, the Gleason score, the undergrading of Gleason score is a possibility. We see some statistical data for the prostate biopsies. The cancer detection rate in primary biopsies is about 35 or 40%, whereas the cancer not identified in the remaining 60% of the patients is about 25%. So when we think about the locations of these cancers, the missed cancers are usually in apex, transition zone, and anterior horns of the peripheral zone. It's possible to evaluate these regions on MRI. When we take into account the total number of biopsies performed in the United States, we can see that some 175,000 cancers are missed with conventional biopsies. This is a quite high number. So as a solution, some technical refinements of imaging is in the agenda for the last 5 or 6 years. This is called MR-guided biopsy. The MR-guided biopsy may rely on direct MR-guided in-bore biopsy, which means the sampling of the prostate gland directly directly with the MRI machine, whereas some fusion technologies may also help us to accurately sample the lesions that we see on MRI. So these techniques rely on co-registration of stored MRI images that we have before the biopsy with the real-time ultrasound image by means of a fusion device. So the suspicious targets are marked on diagnostic MRI, and we give a score to these lesions. And as I said, with the use of some softwares, the co-registration of these images with the real-time ultrasound images can be possible. I hope this will work, but I'm not sure. I'm sorry for this. This was a quite nice video for the use of fusion technique for the fusion of MRI and ultrasound images, but unfortunately it doesn't work. So I will move to the other video, but this is again not working. So what's the outcome for fusion? The cancer detection rate is quite high, especially in suspicious lesions. I mean, the lesions that are marked accurately on MRI, the outcome is about 100%. And for each targeted biopsy, in comparison with the conventional biopsy, the cancer detection rate is about 3 to 5 times higher. And especially the significant cancers, which means cancers that should be treated without any doubt, are sampled only with targeted biopsies. So the accuracy in sampling the biopsied cores or the lesions increases with the use of fusion technique. Here is an example: a patient, 72-year-old, with a high PSA level, with a history of 2 negative biopsies. So 2 conventional biopsies were performed, but the outcome was unfortunately negative. But the PSA is still suspicious. So what we do is doing an MRI. We see the axial scans, the transverse scans on MRI. Here is a suspicious lesion in the left anterior horn, which is a typical area for missed cancers. And with the functional sequences, again, we confirm the presence of an abnormality here. And the fusion biopsy was performed, and left anterior horn was known to have a prostate cancer with Gleason score 7. What is the meaning of all these things, all this stuff that we have been doing with the prostate? So here's a quote from an important journal from 2012. It says, if the past quarter century has brought minimally invasive procedures, the next may bring the elimination of invasion for the management of prostate cancer and other diseases as well. This is very important for prostate cancer because we know that the behavior of prostate cancer, or the clinical behavior of prostate cancer, relies on the clinical behavior of index lesion that we see on MRI, as we see here. And we also know that by means of all this fusion technique and the other accurate techniques, it is possible to detect this index lesion technically with a higher accuracy. And when we detect the index lesion, it's possible to give a source of energy to this lesion and to treat the disorder, to treat the disease. For prostate cancer, there are different modes of energy that can be used, but the important thing, as I said, is to mark or to see the prostate cancer in a precise manner. And the focal treatment aims to preserve as much tissue as is compatible with treating the target volume plus a certain degree of margin, and to protect key structures from injury. We know that their integrity is essential for genitourinary function. This is an important problem. I'm sure the urologists will agree with this for prostate cancer management, because the conventional treatment tools may have some significant morbidity, like some problems with the genitourinary function. And all these treatments are not competing with each other, but they are complementary. So some sorts of prostate cancer will need whole gland treatment, whereas some may only be observed with active surveillance, and those in between may have focal therapy. So this is in relation with the severity of the disease, as you know. And as a take-home message, I will say multiparametric MRI and other tools of imaging may provide a better picture of primary or recurrent prostate cancer, and this may improve the technique of the prostate biopsies, and in turn, this may promote the application of minimal invasive or non-invasive treatment focal treatment tools, resulting in lesser morbidity. Thank you for your attention.
Thank you, Professor Turgut. Any question or comment? Okay. Thank you. We move on to the next speaker, Professor Ali Ünsal from Gazi University, Faculty of Medicine, Urology Department. He will talk on about the really tricky point of the retrograde intrarenal surgery. That is one of our targeted surgical techniques you will perform tomorrow. The indications and tips and tricks of retrograde intrarenal surgery. Please, Professor Ünsal.
Good morning. Thank you very much. I would like thanks organizing committee, and also thanks to Dr. Emre Huri for inviting me here. I would also thanks Dr. Oliver Trexer from France, because I used some slides of him for prepare this talking. Yes. Where we use ureteroscopy or flexible ureteroscopy, we use it for diagnosis of ureteral tumors, for diagnosis of upper urinary tract tumors. We use for stone treatment, we use for tumor ablation, and we use for incision in the urinary tract for UPG, junction obstruction, and for other purposes. When you look at AUA guidelines for ureteral stones, stones bigger than 10 millimeter, ureteroscopy is the first option. When we look at the renal stones, also stones small than 20 millimeter, ureteroscopy is the first options, and sometimes stone bigger than 1 centimeter, flexible ureteroscopy become first option. There are a lot of rigid and flexible ureteroscopes in the market. Some of them are fiber optic, and some of them are digital. When you use a digital ureteroscope, you may be fast, more fast than the fiber optics. This is some kind of tips and flexible ureteroscopes in the market. when we compare them, the working channel is nearly same in all kinds, but tip diameter is different. It's begin from 5 French, 5.4 French to the 8.5 French, but proximal diameter is bigger. It's start from 8 French and to 9 French. When we look at the anatomy of the ureter, the diameter of ureter is 10 French, but we have 3 narrowing parts. One of them is UPG junction, it's nearly 6 French. One of them is the area of crossing vessels, and the third part is intramural part. Should we do pre-stenting or balloon dilatation for all patients? No, there is no need to do systematically pre-stenting, but this is for adult patients. In pediatric patients, all patients younger than 8 years old, systematic pre-stenting is needed for the ureteral orifice dilatation. With some maneuvers, you can easily insert the ureteroscope over a guide wire, digital or flexible or rigid ureteroscope. You can pass over the guide wire. Traumatic ureteral orifice structure is less than 2%. How we manipulate the flexible ureteroscope? There are 3 manipulation, 3 movement. One is vertical movement. You use this maneuver for deflection or up-down, declaration of up or down in the vertical position. When you move horizontal plane, you should rotate your hand, and when you for the deep movement, you push or remove the flexible ureteroscope. But in the market there are 2 main ureteroscope. One of European model. In the European model, when you deflect up, the tip go down. When you go down, the tip go up. But in the American model, when you push up, the tips go up. When you push down, the tips go down. So you have to know which one you use. For the going into the kidney, in the right side, when you go in the right kidney, you will see the calyces on the left screen. In the left side, you will see on the right side of the screen, the calyces. This is an in vitro study. Stone movement is very important during the also rigid ureteroscopy and flexible ureteroscopy. In this study, in the same energy setting, small and large laser fibers are compared, and with the largest fiber, the retroposition or moment of stone is longer than the smallest one. So, take-home message: less retroposition can be achieved with smallest fiber. It's compared with different energy settings. When you increase the energy, also retroposition is increased according to this in vitro study. So, especially in the ureteral stone, you have to use smallest fibers and with small energy settings. Shall we do fragments or dusting? What is fragments or what is dusting in the kidney stones? For the fragmentation, the energy setting will be high, but frequency will be low. 4 to 6 hertz is enough. The power setting will be 4 to 10 watt. For a 1 centimeter stones, if you fragment to 5 millimeter, it will be 8 pieces. But if the stones become 2 centimeters, it will be 64 pieces when you fragment bigger stones. So stones small than 1 centimeter fragmentation is okay, but in the biggest stones you cannot remove all of the stones, so dusting is more more achievable. Also, for when you do fragmentation, you have to use some baskets. These baskets should be tipless and it should be nitinols. And there are a lot of kind of baskets in the market, but they are some expensive. And what is dusting? For dusting, you have to increase the frequency over the 10 hertz, and you should decrease the energy and don't touch the stone. Begin from the center to peripherally. Yes. But if you need stone piece for analysis, you have to make some fragmentation. It's especially important for the pediatric patients for metabolic evaluation. What about incision? During the incision, you have to increase your power and you have to increase your frequency above the 10, near 20 hertz, and you have to increase also your power. We can use incision for stone disease also. This is a medullary sponge kidney. You can incise the mucosa over the stones and remove them. Also, we can use the incision for strictures in the ureter, in the UPG or in anywhere the ureter. For uretropelvic junction obstruction, on the right side we have to incise the posterolaterally because of the vessels. It's around 7 o'clock. On the left side it's around 5 o'clock. What about tumor ablation? During the tumor ablation, you have to increase also your power in high settings. Increase should be 10 or higher, and your joule is around 1 joule. And during the tumor ablation, you should not touch the tumor. And what about vision? Vision is very important during the endourology, especially during the flexible ureteroscopy. Vision is very important, as the working channel of most flexible ureteroscopy is 3.6 French. So in the 1 minute, 40 milliliters of water can decrease from there, can come from there. But if you use a smallest basket or even a laser, the water is decreased very well. For irrigation, there are some special port seals in the market. You have to use them for preservation of irrigation and to fix the laser. And there are some irrigation pumps in the market. You can use one of them during the procedure. But you didn't. You should not use the high pressure because piolovenous backflow may become as 1 millimeter cure is nearly 1.3 centimeter water. So the water height should be nearly 6 centimeter is ideal for the surgery. What about the guide wires? In the beginning of the procedure, you should use the 2 guide wires, one for safety guide wires, one for working guide wires, even for putting a ureteral access sheet or for flexible ureteroscope. Stiff guide wires is better than the others. It's easy to use. And what about ureteral access sheets? There are a lot of kind of ureteral sheets in the market also. The ureteral access sheet facilitate multiple anti-exist, maintain low intrarenal pressure, facilitate irrigation, and protect your flexible ureteroscopes. This is a new access sheet. You can use one guide, and when you remove the access sheet, you can leave the guide in the ureter for safety guide. But access sheets sometimes may be dangerous for the ureter. This is a study from Traxer. Traxer see that if there is a small mucosal injury, it's type 1, and more injury type 2, and whole injuries in ureter type 3, and they see there are severe injury type 2 and type 3 in nearly 10% of patients. Is it need a double J stent after the procedure? If the procedure is uncomplicated and if the procedure is not longer than 1 hour, there is no need any double J stent. But otherwise, you should put a double J stent after the rigid or flexible ureteroscopy. Thank you for your attention.
Thank you, Professor Ünsal. Any questions or comments? I have one question. What is your suggestion to our students, residents, to start for training purposes retrograde intrarenal surgery using the flexible ureteral anoscope?
Firstly, you have to use rigid ones. You have to learn to introduce a rigid ureteroscope to the ureter, and then turn the flexible ones. And if you use flexible cystoscopes, because cystoscopes is easy then to go in the ureter, you can use first a flexible cystoscopes in the bladder, then turn the flexible ureteroscope. Always, if you can put a sheet, always put a ureteral access sheet, but smallest one. If you cannot introduce a sheet, you can introduce the flexible ureteroscope over the guide wire.
Thank you very much. Thank you. Now we have a little bit small program change because of the time. Now we will have a lunch break. We will start at 1 o'clock here. At 1 o'clock, please, because in the afternoon session we have one special meeting, the webinar conference with the United States, IEEE 3D-based medical application working group meeting. So we have to finalize all theoretical part at 3 p.m. today. So we will start at 1 o'clock. I would like to request some points. The first, please fill the anatomy form. Questions, 10 questions. Please fill it and then secure, okay? And you have two forms. Trainee evaluation form. You will fill the trainee evaluation form and then leave for after. It will be tomorrow, okay? Tomorrow at the end of the meeting, after the meeting, and we will fill the instructor form tomorrow for you during the training session. We are closing the session, and have a good lunch.